So this has been a fairly long session, and this is the last formal talk already. And as we have heard throughout the day, really a lot of progress has been made in myeloma therapeutics in the last decade or so with the introduction of novel agents such as thalidomide, bortezomib, and lenalidomide. And that has led to tremendous improvement in the overall survival of our patients, almost doubling from about 4 to 5 years to now 7, 8 to even 10 years. So this has been tremendous progress, but with that progress, patients are still actually relapsing, and the long-term cure is actually still not a viable objective for most of these patients. So I think an important area that physicians are now starting to face is what happens when patients relapse after these very potent treatment that actually has led to so much improvement in response rates, and these are reflected by all these bars down here. The blue bars actually represent overall response, red VGPR and better, and in green complete response rate. So this is an old VAD regimen, the infusional chemotherapy combination that has very little CR, but with the introduction of these novel agents and the use in combinations, and you can see, you can just follow the green bar, this has actually led to incremental increase in this CR rate to the point that nowadays, with some of the regimens that we are actually using, like cyclophosphamide, Velcade, and dexamethasone, you can get a CR rate of about 40%. And then with VRD or the 4-drug combination, you're actually getting an overall response rate of about 100%. So that's pretty remarkable, and that's explained the improvement in the outcome. But what happens when patients relapse after all these regimens, after being exposed to Revlimid, being exposed to Velcade, and they're progressing or relapsing on this treatment? Where is the data for those group of patients? So this is work done by Shaji Kumar and this from Mayo Clinic, and this is work done through the International Myeloma Working Group that hopefully will be coming out soon and has been alluded to by the previous speakers, where he actually looked at the response to subsequent treatment following relapse for patients who relapse after both Velcade and Revlimid, and what is their survival outcome. So you can see that from this response rate curve that only about 4% of patients that have relapsed from Revlimid and Velcade previously achieve a complete response, and only 11% a very good partial response, and partial response rate is only 38%. So this is clearly quite different from the population where you were treating them up front or even in first relapse. And the survival is actually pretty dismal. The event-free survival is only about 6 months, and the overall survival is less than 1 month. So this clearly represents a group of patients that we have to have better strategy to manage. But I guess the news is not bleak, because there are a lot of emerging therapies, and which has been again mentioned already before in passing. I'm just going to highlight a few that is perhaps the closest to the clinic, to approval. And this will be carfilzomib, pomalidomide, and vorinostat being one of the HDAC inhibitor, but there are data that suggest that this may be a class effect. There are other HDAC inhibitors such as panobinostat that is appearing to be very active, especially in combination with some of the existing novel agents. And then I'm just going to list down some of the others that are perhaps going to be coming through as well. So carfilzomib is a second-generation proteasome inhibitor. Unlike bortezomib, it is a irreversible proteasome inhibitor, and a number of studies have been done, and I'm just going to highlight a couple. Here is the phase 2 study in relapsed refractory myeloma that was presented at ASH in 2008. And in here, carfilzomib was given for 12 cycles in this dosing regimen, day 1, 2, 8, 9, 15, 16 in a 28-day cycles, and it's given intravenous 20 milligrams per meter squared. Inclusion criteria: patients that have at least relapsed from 2 prior rounds of or regimens and are refractory to the last treatment with less than 25% response, or had progressed on previous treatment within 60 days. And the primary endpoint is overall response rate. And there are about 46 patients accrued, 39 was evaluable for response. 78% refractory to prior treatment, 22% progress on prior treatment. And you can see here, these are really patients that are heavily pre-treated with a median prior therapy ranging from 2 to 15 lines of prior treatment and median of 5. And you can see that majority of them had at least 4 prior therapies, 100% with prior bortezomib exposure, and 57% bortezomib was given in the last round of treatment. And again, many of them had prior exposure to stem cell transplant, thalidomide, and lenalidomide. And 78% of these patients have some form of baseline peripheral neuropathy, grade 1 or 2. And the response in this group of heavily pretreated patient is fairly significant, and 26% clinical response. If you break down, 13% PR, 13% minimal response, 41% stabilization of disease. There's no CR in this small cohort of patients, but in this heavily pretreated group of patients, you can see from the Shaji Kumar's analysis that it's very difficult to achieve a CR. So the response in this group of patients was achieved in a rapid fashion. 6 out of 10 responders was seen after just 1 cycle of treatment, and the response was actually durable with PR and MR sustained for 8 months. And so that has led to a larger study that was actually presented at ASH last year, where they have modified the protocol a bit with the first cycle 20 milligrams per meter squared in the same dosing regimen, and then escalating up to 27 milligrams per meter squared. And with the primary endpoint, again, looking at the response, and secondary endpoint looking at survival. And this is a larger study with 266 patients enrolled, and 257 of these patients with evaluable response. And again, this is a very heavily pretreated group of patients so this group of patients, the characteristic is that they, about 63 years old, and median time from diagnosis was about 5.4 years. And the rest of it just shows us that this is a composite group with fairly, the kind of pattern that you would expect of patients of this category, with about 30% of unfavorable cytogenetics and 31% stage 3 ISS disease. And again, about 80% of patients have some form of neuropathy entering into these studies. Again, heavily pretreated, median 5 lines of prior treatment, with 80% and more having at least 4 prior lines of therapy. And most of them has been treated with bortezomib previously, or one of the IMiDs drug. And in fact, many of them has had at least 2 prior lines of treatment that contains bortezomib, and is refractory to bortezomib in large percentage of these patients in previous treatment. And again, the response has been very encouraging. In this particular larger cohort, there has been 1 patient who achieved CR, 13 VGPR, 14 patients achieving PR. So considering overall response rates is 24%, clinically beneficial response, if you include minimal response, is up to a third of patients, and if you include stabilization of disease, it's about 2/3 of patients. So very, very encouraging response in very, very heavily pretreated group of patients again. And when you look at the subsets, the response seemed to be equivalent for those that have more than 5 lines or less than 5 lines of treatment, high or lower percentage of plasma cells involvement, unfavorable or favorable cytogenetics category, as well as whether they have baselines peripheral neuropathy or not. They seem to benefit equally from this treatment. And again, whether they have more or less prior lines of bortezomib treatment, whether they are relapsed or refractory with prior bortezomib treatment, they have fairly good response rate with sustained response of, again, up to 8 months or more. The progression-free survival for this group of patients on this trial is 3.5 months, thereabout. And the progression-free survival is better for those that have managed to achieve at least a minimal response. For overall survival, this is again quite encouraging for this group of heavily pretreated patients. It's going up to 15 months. And if you remember, again, going back to Shaji's curve, the overall survival of this cohort of patients is generally less than a year. So this is more than a year now. And again, the overall survival predominantly benefit is seen in those that achieve some sort of minimal response. In terms of toxicity, this treatment is fairly well tolerated. The main toxicity are those of hematologic toxicity, but manageable. And again, as hematologists, these are toxicity that generally we know how to manage. Non-hematologic toxicity is minor. Peripheral neuropathy for this drug, although it's a proteasome inhibitor, is actually very, very mild. In terms of additional safety data, the discontinuation from the drug is not high, and death due to AEs on this trial is again not high. And about 20% of patients managed to complete all 12 cycles of treatment. So the conclusion from this study by the authors was that single-agent carfilzomib is active in heavily pretreated myeloma patients whose disease were refractory to their last line of therapy. Overall response rate is impressive with more than a year of overall survival. A third of patients achieve some sort of minimal response or higher. And the response, both progression-free and overall survival, is better for those that achieve this kind of response. And it's well tolerated in this group of heavily pretreated patients with very low rate of neuropathy. So that's carfilzomib. The other exciting drug is pomalidomide, which has been studied, and a number of phase 2 studies have been published. And most of this work has been led by the group at Mayo Clinic, Martha Lacey, as well as Dana-Farber through Paul Richardson and Ken Anderson. And this is the way that, one of the ways of giving pomalidomide 2 milligrams 2 milligrams daily over 28 days with dexamethasone given on a weekly basis. And they usually give aspirin for VTE thromboprophylaxis. And in this first study that was published in JCO 2 years ago now, is in a cohort of patients that have received 1 or 3 lines of prior treatment. And again, the primary objective for most of these phase 2 studies is looking at response rates. And it's pretty impressive. Most of the patients actually achieve some sort of minimal response or more, with several patients achieving close to a VGPR at 12 weeks, meaning after 3 cycles of treatment. And since then, there has been a few other studies that look at slightly different dose regimen. These are actually essentially studies mostly from, again, I said, the Martha Lacey and Mayo Clinic, and Paul from Dana-Farber. And you can see that if it's earlier on in the treatment, the patients have much higher response rate, and naturally, if you treat them at later lines when you have more heavily pretreated patients, the response rate will be lower. But nevertheless, all these response rates were extremely encouraging. But those were a more mixed bag group of patients. So at ASH, the Mayo Clinic asked the question, what about the use of pomalidomide in patients that have been relapsed refractory to both lenalidomide and bortezomib? So, and they wanted to also compare whether there's a difference between giving 4 milligrams and 2 milligrams of the drug. And the way they give this drug, again, is every day for 28 days in a cycle, so there's no rest period. And dexamethasone is given weekly, and they have 2 arms, one where pomalidomide is given 2 milligrams and one where it's given by 4 milligrams. And again, aspirin is used. And if there is no response, or if there's progression after 2 cycles, there is room to increase the 2 milligram cohort to 4 milligram a day. And this is just to show that the 2 groups are very comparable in terms of age, months from diagnosis, and tumor burden as indicated by labeling index and beta-2 microglobulin. And in terms of the risk category of these group of patients, all the high-risk category are represented here, 17p deletion, 414, 1416, and this constitutes a substantial percentage of these patients, about 2/3, 50 to 60%. And these are their prior drug exposure. So by definition, 100% of these patients would have to be exposed previously to both lenalidomide and bortezomib. And you can see too that large percentage of these patients have had transplants as well as lenalidomide exposure. Toxicity is not bad at all. I mean, again, predominantly hematologic toxicity. Neutropenia is the predominant problem. But if you use the 2 milligram cohort, grade 3 and 4 neutropenia is much less of a problem. So in terms of toxicity, at least the 2 milligrams seems to be better. And again, non-hematologic mainly is fatigue and peripheral neuropathy, but the neuropathy here is usually of grade 1, 2 nature, so very rarely do you get grade 3. Again, looking at this graph, you can see that for the 4 milligram cohort, there's just higher, more amount of more significant grade 3, 4 toxicity. In terms of response rate, again, this is very encouraging. Between the 2 milligrams and 4 milligram cohort, about the same, 40 to 50% at least achieving a minimal response. This is very similar to what we see, or maybe a bit higher to what we see with the carfilzomib trials. But there's no significant difference between these two. In terms of just the more traditional way of defining response of more than PR is 26%, similar in both arms. What about those that has high-risk genetics? High-risk genetics group responds well to is 33% of responders, although the response is higher with standard risk patients at 54%. In terms of the overall time taken to respond, again, this is very rapid at about 1 to 2 months, meaning 1 or 2 cycles of this treatment. Duration of response is sustained for more than 12 months or at 12 months, and survival at 6 months, because the follow-up of these patients are shorter, is about 70 to 80%, which is, again, very promising. So the conclusion from the authors is that PomDex has significant activity in this heavily pretreated population who are refractory to lenalidomide and bortezomib. Response rate is good. Durable response to 12 months. Overall survival at 6 months is 70-80%, which is, again, good. Response is very rapid, toxicity was manageable, and it is also effective in high-risk patients, and hence, in a future study, they will want to see actually if starting at 4 milligrams for 28 days with a rest period may produce the same response rate. So for pomalidomide, there's still some scope to see whether we can tweak the dosing regimen a bit better. What about vorinostat? So these first two drugs are drugs that actually have significant single-agent activity, which is obviously a big hope, because that's where Revlimid and Velcade actually got their start, is significant single-agent activity, or combined with dexamethasone, and nowadays they are used up front. So for these two treatments, there's scope for future use early on in disease, which may, again, improve patients' outcome. But vorinostat is a class of drug, the HDAC inhibitor, that target epigenetic pathways that seems to work better when it's used in combination with other drugs. And we think that it is perhaps working to overcoming some of these drug-resistant mechanisms that actually lead to refractoriness or poor response to Velcade and lenalidomide. So this is a published phase 1 study already from Ashraf Badros as a first author. And interestingly, the background is that there had been a phase 1 study published from Paul Richardson of single-agent vorinostat that shows that as a single agent, it really doesn't have very good activity. But there's a lot of preclinical data to suggest that HDAC inhibitor can synergize with Velcade and can overcome some of the drug resistance that we see in vitro. This combination study was done, and the primary objective, as most phase 1 study, is to look at MTD and to get some glimpse of PK/PD and to see whether we can see any response in the initial cohort of patients. And so these are patients that have at least 3 prior lines of treatment and have other pretty standard inclusion criteria for clinical trial patients in terms of ECOG status and so on. And the study is a phase 1 trial looking at dose escalation of bortezomib at 1 to 1.3 milligrams per meter squared given in the standard fashion, and vorinostat at 100 to 500 milligrams orally daily for 8 days of each 21-day cycle in this relapse group of patients. And they also look at PK and PD. And so you can see again in terms of the cohort of patients and then the number of prior treatment, these are again very heavily pre-treated patients with median 7 prior regimens. Many of them had had transplant and had exposure to one of the IMiDs or bortezomib. And in this group of patients, we see encouraging response of VGPR and PR as well, including those that has been previously refractory or had progressed on bortezomib. So suggesting that the addition of HDAC can actually bring back response to this group of patients that have previously lost their response to Velcade. In terms of toxicity, this drug, on the whole, again, appeared to be, or this combination appeared to be fairly well tolerated, with very few grade 3, 4 toxicity. So the conclusion from this paper is that they found the MTD, which is vorinostat, at a dose of 400 milligram daily for 8 days, together with Velcade at 1.3 milligrams per meter squared. And it has encouraging activity already in this phase 1 setting. Even in patients that are previously bortezomib unresponsive, it seems to be able to bring about some response. And that phase 2 and 3 clinical trials are actually currently planned and, in fact, are ongoing. And there was an abstract in ASH where they looked more specifically at groups of patients that, again, has failed bortezomib DAX or LANDAX or even VRD in a very kind of refractory group of patients. Very encouraging for this group of patients, with 43% achieving at least a PR, and 89%, if you include those that have at least stabilization of the disease. Duration of response is quite variable. Numbers are small at this stage, so we can't make too much conclusion on this, but impressively, there were patients that have response durable for more than 23 months. Toxicity, most commonly GI and some hematologic toxicity, but no additional cytopenias that one would expect for patients treated with Revlimid. So, those are very encouraging results, and again, I think for the HDAC, it is a class effect because panobinostat, which is another HDAC inhibitor, is also shown to be very effective, at least in phase 2 clinical trial setting, combined with Velcade. And so that, as a class of drug, I think potentially has, is going to be very exciting for myeloma treatment in the future. And as alluded to by other speakers already, there's a whole bunch of other drugs that currently are in clinical trials, either in combination, usually for this, with either Velcade or Revlimid or one of these novel agents, and also some class of monoclonal antibodies. Again, some previous speakers alluded to this, that again may be very exciting, and clinical trials are currently ongoing. So overall, in conclusion, I would say that although the data that is going to be presented seems to suggest that patients refractory to Velcade or relapsing following Velcade and Revlimid is pretty dismal at the moment, but there's hope for the future, and some of these may be coming online pretty soon, within a year or two. Some of these drugs actually excitingly have significant single drug activity, or at least when combined with just dexamethasone, and this will definitely increase our armamentarium. Some of these drugs are best used in combination and seems to be able to overcome resistance to prior therapy. It's been in clinical trials whenever that's available, especially in our region, in relapse refractory setting. And in future, I think the challenge is to put together the jigsaw to find the most rational use of this drug, because I think the number of pieces is going to increase in this jigsaw puzzle. So that may actually lead to more confusion and more challenges. But I think it's a happy situation that we're in now. So with that, I will conclude my talk, and thank you very much for your attention.